right, so mitral regurgitation is the other um, is the other mitral valvular lesion that we're going to look at. And when we say mitral regurgitation, we actually mean there is a backflow of blood across the mitral valve from the left ventricle back into the left atrium. Remember, the normal flow is from the left atrium across the mitral valve into the left ventricle, and that occurs in diastole. In systole, the mitral valve closed. So if the valve is competent, there shouldn't be any backflow of blood from the left ventricle back into the left atrium once the valve is competent. If the valve is incompetent, then in systole, when the left ventricle contracts, you're going to get blood flowing from the left ventricle across the mitral valve into the left atrium. And that is what we call mitral regurgitation. Now, mitral regurgitation can have different etiology, and we're going to look at the different etiology, what caused mitral regurgitation. And then we're going to look at what type of symptoms and what signs is associated with mitral regurgitation, and then how to quantify the mitral regurgitation. Is it mild? Is it moderate? Is it severe? Okay. All right. So what are some of the more common causes of mitral regurgitation? So one of the most common cause of mitral regurgitation is mitral valve prolapse, the so-called myxomatous degeneration of the mitral valve. It's redundant. There's a redundancy. It's just too much. So because there's just too much of the mitral valve, it's redundant. We call it also the flappy valve syndrome. It does not close properly, and you get regurgitation. So one of the more common name for it is mitral valve prolapse. But it's a very significant cause of mitral regurgitation, especially in the United States and Europe. Ischemic heart disease, another very large cause for mitral regurgitation, because as you can recall, when the mitral valve closes, it's dependent on proper functioning of the papillary muscles and the chordinae tendineae. So if you have ischemic heart disease, and when we say ischemic heart disease, decreased blood flow to the papillary muscles, and hence the papillary muscle become dysfunctional, and you're going to get improper closure of the mitral valve. So that's a very important cause of mitral regurgitation as well. In the developing countries, rheumatic mitral valvular disorder is very common. More common than in the United States and Europe. So rheumatic heart disease, significant cause of mitral regurgitation. Marfan syndrome. Marfan syndrome don't only affect the aortic valve, but it can affect the mitral valve, and you can get mitral regurgitation. Ehlers-Danlos similarly not only affect the aortic valve, but it can affect the mitral valve, and you can get mitral regurgitation. Dilated cardiomyopathy. Dilated cardiomyopathy, where the valve, because everything is dilated, the valve does not cohort properly, the valve does not close properly, hence the valve is incompetent, and you're going to get regurgitation. Non-compaction cardiomyopathy is the same thing. You get a dilated cardiomyopathy, improper closure of the valve, so you get regurgitation. Endocarditis, so these infected materials which forms on the the vegetation form on the valve and again prevents proper coaptation of the valve or closure of the valve. What are some of the signs and symptoms of mitral regurgitation? Of course, it depends on the severity. If the mitral regurgitation is very mild, then the patient will be asymptomatic. Even if you can have severe mitral regurgitation and patient is still asymptomatic. So, but if the patient has mitral regurgitation and symptomatic, the symptoms and the signs and symptoms that they will present with shortness of breath. Shortness of breath is so. As you can recall, most of the valvular lesions going to give you, if the patient is symptomatic, they're going to have shortness of breath. So shortness of breath, and it will start with shortness of breath with exertion. That is whenever the patient walk, do any activity, they become short of breath. Once it gets more severe, then they have what we call PND, paroxysmal nocturnal dyspnea. They cannot, they go to bed and a few hours later they have to jump up in bed to breathe. It's PND. As opposed to orthopnea, they just can't lie flat. They tell you, they start out using 2 pillows, 3 pillows, and then they're now sleeping in the recliner because they cannot lie flat. It's orthopnea. And of course, congestive heart failure, where the cardiac output reduce significantly and the lungs is filled with fluid. Decreased exercise tolerance because of decreased cardiac output. Palpitation because these patients are prone to arrhythmias, atrial and ventricular arrhythmias. Okay, so palpitations. The classic murmur for mitral stenosis is an holosystolic murmur. And when we say holosystolic, mean the murmur occurs throughout all of throughout systole. So it's a holosystolic murmur. All of systole, okay, and it's classically heard at the apex, which radiates to the axilla, radiating to the axilla. So that's a classic murmur for mitral regurgitation. So you can listen to the patient chest and say, oh yeah, this patient have mitral regurgitation, okay, and because of the regurgitation. So when you have regurgitation, so blood is constantly going back into the atrium. So the atrium is going to get larger and larger. But not only the atrium going to get larger and larger, the ventricle is also going to enlarge because more blood into the atrium, more blood into the ventricle. More blood into the atrium, more blood into the ventricle. So both the left atrium and the left ventricle is going to enlarge. And you're going to get a displaced apical beat. So when you can put your finger over the apex and it will be displaced. It's not going to be in the fifth intercostal space. The mid-clavicular line is going to be either more laterally or inferior. And with the mitral valve prolapse, the classic, you tend to get a mid-systolic click. So that's sort of classic for mitral valve prolapse. So, all right. So you guys have seen, this is our parasternal long axis view, and you can see our sectors across the mitral valve, and this is supposed to be a systolic frame because the aortic valve is open, the mitral valve is closed, but even though the mitral valve is closed, we still see something going across the mitral valve. So this is a flow from the left ventricle across the mitral valve into the left atrium. And this is classically what your color flow Doppler looks like in mitral regurgitation. Okay, so that is your left atrium right there. And your left ventricle is right there. Okay, and you saw, so of course, then this is your Remember what we said, when you get turbulence, you get a mosaic of color, a mixture of color. So this is what your mitral regurgitation looks like. In the apical four-chamber view, so your left ventricle is on top, left atrium is right there. This is your mitral valve, and this is your color flow telling you that there's mitral regurgitation. So the mitral regurgitation is a systolic phenomenon. You always have your ECG down below. So again, systole is from the onset of the QRS to the end of the T wave. So if you map this out, you'll see it's a systolic flow. And in systole, the mitral valve is supposed to be closed, but this is incompetent. So that's why you have the mitral regurgitation right there. So that's your. So that is your anterior mitral leaflet right there. And that is your mitral valve plane. So when we talk about mitral valve prolapse, what we're actually saying is that the mitral valve is bending backwards into the atrium somewhat. There's supposed to be a plane, and this is what we call the mitral valve plane. If the valves comes within a certain distance of this plane, then that's what we call mitral valve prolapse, the left ventricle right there. So this would be, you can see the anterior mitral leaflet sort of bows backwards. So this is what your prolapse of your anterior mitral leaflet looks like. Left atrium, prolapse of your anterior mitral leaflet, and you have to look for it. So with mitral valve prolapse, if you have prolapse of the anterior leaflet, the jet is going to be directed posteriorly. If you have prolapse of the posterior leaflet, the jet is going to be directed anteriorly. So, you cannot, unless you have equal prolapse of the anterior and the posterior leaflet, then you'll probably get a central jet. Okay, so you have to look for that, and that's classic with mitral valve prolapse. So this is prolapse of the posterior leaflet, which this is very dramatic prolapse. So you expect to get the jet going anterior. And when you do your M mode is going to be classic. So your ECG is right there, and you can see the cursor cuts across these structures in the heart, and you're going to look at those structures on the M mode. So you can see the first encounter is the chest wall. So you have the chest wall. After you have the chest wall, then you'll have the subcutaneous tissue going down to the pericardium. Then you have the pericardium, and then you have the right ventricular wall. Okay. Then when you cross this right ventricular wall is right up there. Then you have right ventricular cavity. So all of this is your right ventricular cavity. And then after the right ventricular cavity, then you have your septum. So this represents the septum. Okay. And then inside of the septum, you have the left ventricular cavity and the mitral valve. So this is the left ventricular cavity, and this is the mitral valve. Mitral valve opens in diastole. Just map it up to your ECG. So in diastole, mitral valve opens. In systole, which is right there, mitral valve closed. But in systole, you can see, especially the posterior leaflet prolapse into the left atrium. It prolapse. So this is what your prolapse looks like in systole. It's a systolic phenomenon. Okay, so right ventricular cavity, septum, left atrium. So the valve prolapse into left atrium. So diastole, the valve opens. Systole, the valve is supposed to be closed. Okay, so how do we assess the severity of mitral regurgitation? So when you get a case of mitral regurgitation, one of the first things you have to do is you have to determine the mechanism of the mitral regurgitation. What is causing the mitral regurgitation? Remember what we say, is it a purely valvular problem? Do you have, say, mitral valve prolapse? is the valve fenestrate? Is there a defect in the valve for whatever reason? Okay, or do you have rheumatic heart disease, rheumatic mitral valvular disease, or is it ischemic? It's very important to determine the mechanism, what's causing the mitral regurgitation, because that's going to affect how you treat the patient as well. And then you have to talk about severity, how to determine the severity of mitral regurgitation. So you're going to look at the leaflets, okay? So the valve apparatus, you look at everything that's affecting the valve. So the leaflet itself, you're going to look at it. Patient have mitral valve prolapse. Is there vegetation? Is there a perforation? You look at the coordinate tendineae, because the coordinate tendineae anchors the valve to the papillary muscle. Do you have rupture of a few of them? Are they short and calcified? Then you look at the annulus. You look at the mitral annulus. Is the annulus dilated so the valve is not coapting properly? And then again, the papillary muscles, because if you have ischemic heart disease, the papillary muscles are not going to contract and you can get significant mitral regurgitation. So again, this is the mitral apparatus here. You have the leaflets, you have the coordinate tendineae, you have the papillary muscles, you have the annulus. All of those things make up the mitral apparatus. So all of those things make up the mitral apparatus. So the mechanism of the mitral regurgitation is important. And once a patient have any type of significant mitral regurgitation, you almost always have to do a transesophageal echo to determine the mechanism. Okay, so this is a patient with mitral valve prolapse, and you can see the prolapse on the T, and then the mitral regurgitation. So you have to look at everything. So again, you have to look at the you need to determine the mechanism to see whether you can repair or replace the valve. You have to look at the left atrial size and left ventricular size as well. Remember what we said, when you have mitral regurgitation, blood is constantly going into the left atrium. It's going to dilate the left atrium, but that blood that's going back into the left atrium have to go forward and into the left ventricle. So the left ventricle is also going to be dilated with significant mitral regurgitation and chronic mitral regurgitation. So this is mainly for chronic mitral regurgitation, not acute. So the size of the ventricle and the ejection fraction, those are things that determine when you should operate, plus symptoms, of course. If the patient is symptomatic, and they have severe MR, regardless what size the ventricle or the atrium is, you're going to fix it. However, mitral regurgitation is a little bit different from the other valvular lesions in that, because in systole, blood is going to be ejected into the left atrium and across the aortic valve. They usually have a super ejection fraction. Ejection fraction is 75%. So if you see a patient with significant mitral regurgitation and the ejection fraction is less than 60%, that patient start to have LV dysfunction, LV systolic dysfunction, and that is a patient that should have mitral valve repair or replacement. Okay, so it's very important that if the ejection fraction starts to fall in these patients, you need to fix the valve. All right, so things that we look at to determine the severity, we look at the regurgitant jet area. If it's small, then it implies mild regurgitation. If it's a large, and when we say small, probably less than 20%, large more than 40%, that suggests severe MR. You cannot use the color alone You have to use other supporting features. The vena contracta is one of the most important, or one of the factors that will give you the severity fairly accurately. So when we talk about the vena contracta, if it's more than 7 millimeters, then it suggests severe MR. If it's less than 3 millimeters, suggests mild. So the vena contracta, which is basically the neck, the width of the neck or the narrowest portion of the jet. So we call the vena contracta. Okay, so again, this is a mitral regurgitation. You can see the mosaic color. It's in diastole, it's in systole because the mitral valve is closed, but the valve is incompetent, so you still get some regurgitation. But this color is probably the area of this jet compared to the area of the left atrium is less than 20%. So it's probably mild. And if you were to measure the vena contracta, the width of the jet, it's probably less than 0.3 centimeters, as opposed to severe, where the color occupies more than 40% of the left atrium, and the vena contracta is going to be more than 0.7 centimeters. Okay, so this is the vena contracta, is the neck. Okay, it's the neck. All right, so you just measure the width, and it's a fairly accurate measure of the severity of the MR. So if you look at your continuous wave Doppler for mild MR, the spectral recording have a soft density. It's faint. You know, it's gonna have a rounded contour, but it's gonna be faint, as opposed to severe MR, where the spectral recording is gonna be dense and triangular. It has a early peaking. So again, this is your mitral regurgitation. Your ECG is on top. So these are systolic. So in systole, you get these envelopes. And of course, we did Doppler. So your transducer is right there. With mitral regurgitation, you're going to get flow from the left ventricle across the mitral valve into the left atrium. The flow is going to be away from the transducer, hence it's going to be below the baseline, below the baseline, below the baseline. So, and it's faint. So this is rounded contour, faint. So that's mild MR, as opposed to severe MR. You can see it's dense, very dense, and a lot of time it's triangular. You have early peaking. Okay, so this is in keeping with severe MR. Another very important feature of severe MR is when you look at the pulmonary vein. Okay, so for mild MR, the pulmonary vein gonna have a fairly normal contour where you have systolic predominance. So you remember your pulmonary vein flow, you have your systolic flow, your diastolic flow. In a normal pulmonary vein flow, the systolic flow is usually larger than the diastolic flow. With severe MR, the pulmonary vein is going to show systolic flow reversal. So this is your normal. So ECG is on top. So this is your pulmonary vein flow, systolic component, diastolic component, systolic component, diastolic. And of course, you have the atrial flow reversal down there. But you can see the systolic component is larger than the diastolic component, which is in keeping with mild mitral regurgitation, as opposed to your severe, where you have systolic flow reversal, The diastolic flow is fairly prominent, but systolic flow is reversed. So that's in keeping with severe. Remember, when we did hemodynamics, we look at PISA. We look at PISA, and again, we calculate what we call the EROA. So the regurgitant flow, which is the EROA times the maximum mitral velocity, is equal to the flow at PISA. okay, which is equal to the area of the hemisphere times the Ailesbury velocity. So the EROA is equal to this, okay? EROA is the effective regurgitant orifice area. Basically, what this is saying is the larger the regurgitation, the larger the area. The larger the regurgitation, the larger the area. So the when the regurgitation is small, then the area is going to be small. Just think about it a little bit. So a lot of regurgitation, big area. That's basically what it's saying. And this is how you calculate it, however. And we did that in hemodynamics. So again, this is your regurgitant flow right here into the left atrium. Then into the left ventricle, you get your hemispheres, your shells, okay? So again, your proximal isovelocity area, left ventricle, pizza, regurgitant jet, left atrium, okay? So you could measure your vena contracta. This is your hemisphere up there. You can measure the radius, okay? All right, so some important features. If your Ailesbury velocity is 40 centimeters per second and the mitral regurgitant velocity is 5 meters per second, if you substitute these numbers in this equation, then your EROA is equal to R squared over 2. So all you have to do is measure the radius of the hemisphere and square it and divide it by 2, and you get the EROA. And they love to do this in exam. They'll tell you that Ailesbury velocity was set at 40, and they probably won't tell you that the MR velocity is 5, but they'll give you a Doppler with the velocity, and then it's 5. If once you look at it, you see it's 5. So you don't go through the full equation. So the EROA is R squared over 2, and then they're going to ask you what's the severity of the MR. Okay, so you have to remember that. And another one is if the Ailesbury velocity is 30 centimeters per second, and the regurgitation mitral regurgitation velocity is 5 meters per second, then if the radius is greater than 1 centimeter, then the MR is severe. Because if you plug all those in the equation, EROA is going to be greater than 0.4 centimeters squared. All right, again, if you want to calculate the regurgitant volume, remember it's the EROA. So wherever you get the EROA from, you multiply it by the TVI. So you just, you're playing that, and you'll get the TVI multiplied with 2, and you'll get the regurgitant volume. Okay? And then to get regurgitant fraction, it's regurgitant volume over the mitral inflow. And you get that. So to get the mitral inflow, flow again is area times TVI. So this is the mitral area, mitral valve area times the TVI of the mitral. Okay. So you can get your whatever calculations you want, you can get it. Okay. So this is the table that you need to know. This is the table that you need to know. So for severe mitral regurgitation, the left atrium is usually dilated because blood is constantly flowing into the left atrium. The left ventricle is also usually dilated. We're talking about severe MR. When you look at sometimes when you look at the leaflet, depends on what you might see a flail mitral leaflet or a ruptured papillary muscle to explain the severity of the MR. When you look at your color flow jet, then the color flow jet is usually more than 40% of the left atrium. That's in keeping with severe. Or you have a Cohander effect. It loops around the wall, impinge on the wall of the left atrium. So there's updates in this. This says E velocity is usually greater than 1.2. So the current thing is 1.5. So it should be E velocity usually greater than 1.5 meters per second, because there's a lot of blood flowing. There's a lot of blood flowing into the left atrium. So what's going to come across the mitral valve in diastole is going to be a lot of blood, and it will be depicted by an increase in your E velocity. You're going to get a dense MR jet, and it's going to be triangular, early peaking, and you get systolic flow reversal in the pulmonary vein. When you look at your vena contracta now, it's greater than or equal to 0.7 centimeters. Regurgitant volume greater than or equal to 60 mLs. Regurgitant fraction greater than or equal to 50%. EROA greater than or equal to 0.4 centimeters squared. So all of this make up severe MR. For mild MR, then the left atrial size usually normal, LV size usually normal, leaflets usually look fairly normal. The color flow jet is usually less than 20% of the left atrial area, and you usually get A dominance in the mitral inflow. In the mitral inflow, usually A dominance. When you look at the jet density, it's usually faint, incomplete, rounded, of course. And then when you look at your pulmonary vein flow, you get your systolic dominance. Vena contracta, less than 0.3 centimeters. Regurgitant volume, less than 30 mLs. Regurgitant fraction, less than 30%. EROA, less than 0.2 centimeters squared. So you need to know how to determine the severity of MR, and how to accurately um, uh, make your determination. All right, so you need to know this table very, very well. Once you know severe, once you know mild, and anything that falls in between is moderate. So you don't have to study the moderate uh, table. Just know the severe and the mild. So